shall be talking on routine non-invasive screening for coronary artery disease among asymptomatic middle-aged adults. Are we there? So this is a question that I need to answer. And before making an attempt to answer, let us look into the guidelines. On the right, you can see the 2021 ESC guidelines. And on the left is the ACC-AHA guidelines. Both these guidelines, in relation to middle-aged adults, recommends calculating 10-year ASCVD risk using the score 2 in case of ESC, and the ACC-AHA uses PCE or the pool cohort equation. And in those who are identified to be at higher risk, ESC guidelines recommends intensification of risk factor treatment. And when it comes to the calculation with this risk scores, they're pretty easy. You can get a score within 30 seconds, and they take into account certain variables like age, smoking status, systolic blood pressure, cholesterol, or HDL-C. However, we are all aware that there are certain issues with risk scores. The predictive value of risk score approach is only moderate. If you look into the C statistics, which looks into the performance of these scores, it is 0.7 to 0.8. And this is, in fact, with most of the risk scores, even CHAT score also has a C statistics of about 0.65 to 0.7. And the risk scores are strongly influenced by age. And this is a Cochrane analysis which has looked into the risk scores, and it involves 41 RCTs, more than 100,000 people. And they came to the conclusion that providing cardiovascular disease risk scores may have little or no effect on cardiovascular disease event compared with usual care. So with risk scores, we are actually on a dodgy ground. So we need to look into the modalities which can improve our risk stratification or which can help us in diagnosing the disease. And my talk is on non-invasive modalities, and I shall be talking on CT coronary angiography and coronary artery calcium scoring. And when you talk about screening, there are certain criteria that needs to be fulfilled. This is the WHO Wilson-Jugner criteria for screening. That a suitable test should be acceptable. The risk, both physical and psychological, should be less than the benefit, and the cost should be balanced against the benefit. So with this in mind, if you look into the CT coronary artery calcium as a screening modality, it can help in reclassifying CVD risk upward and downward. This we have learned from the MESSER study, that in those people who were found to have intermediate risk, say score of 7.5 or 8, and if the coronary artery calcium score comes out to be 0, here we can reclassify them to a lower risk and they will not require any preventive treatment. However, in relation to screening, we need to take into account the healthcare cost, the cost-benefit ratio, and the radiation exposure, though considered to be less, but still it's there. And sometimes you can get non-incidental, non-cardiac findings, which can be a psychological issues on CT coronary artery when you prescribe for CT coronary artery calcium. So all these factors needs to be taken into account. As of now, the recommendation is class 2B, and the clinical trials, there is some gaps, mostly observational studies. However, few randomized studies has come and will be coming in future. This is a Dankovers trial which was published in August 2022 in NEJM, and it is a community-based randomized control trial which included all men aged 65 to 74, and they were randomly assigned into 2:1 ratio to undergo comprehensive screening, including coronary artery calcium, ABI, and blood testing for diabetes mellitus and hypercholesterolemia against no benefit. And the primary outcome was all death from all cause. This is the essence of screening. We must look into the mortality, and the median follow-up was 5 years. This is the intervention that they have taken up in those who are identified to have high calcium scoring above the median score for age and sex. They were given aspirin, atorvastatin, along with a guidance to healthy lifestyle therapy. If you look into the primary outcome, at 5 years, there was no difference in mortality. However, a subgroup analysis has shown that in an age group of 65 to 69 years, there was significant reduction in mortality. So what this trial has shown us is that it has given us a food for thought that if these results can be positive in this age group, we can even think of utilizing these methods in the entire middle-aged group of adults. And encouraged by their study, the investigator has taken up this DANCAVAS 2, where they are looking into 60 to 64 years and will look into their outcome data in 2027. Coming to another trial, this is the Robinska trial, which is a population-based randomized control screening trial. And here, intervention or preventive treatment are given based on the score model or coronary artery calcium scoring and the usual care. However, the outcome analyses are yet to come. A preliminary analysis has been published, which has shown that those who were treated based on coronary artery calcium scoring have a significant lesser requirement of treatment compared to those who were given treatment based on score model. So all these trials has been encouraging. Now I am shifting to another method which is more sensitive and more specific. In fact, it can diagnose the subclinical disease. This is CT coronary angiography. But here you must take into account that it involves high radiation. It is much higher than CT calcium scoring. And contrast media exposure can be an issue, especially in patients who are renally impaired. Cost and logistic is a major issue, especially in our country. You need people who can appropriately refer this patient. You need people who can do this test. You need people who can read the results. And you can well understand these modalities which are not available in small towns. The issue of utilizing these methods for screening is going to be a huge challenge in our country. Clinical trials are limited. We have an ongoing SCOT Heart 2, which is done by David Newby and his colleagues from the British Heart Foundation, funded by British Heart Foundation, which I shall be talking about. And guideline recommendation as of now for screening is class 3. Before going into SCOT Heart 2, let me start with the SCOT Heart 1 trial, which have taken stable chest pain patients and they were randomized into coronary CT angiography or standard care, and they looked into the primary outcome of death from coronary heart disease or non-fatal MI at the end of 5 years, and they have shown reduction with the use of CT angiography. And encouraged by their trial, David Newby and his colleagues has taken up this trial, that is the SCOT Heart 2, where 40 to 70 years of individuals, asymptomatic individuals, this is the age group that we are looking into it. 6,000 individuals, they were randomized to CT angiography or risk score. The risk score used is Assign, which is more validated for the Scottish population, and treatment were given according to guideline-directed therapy. And we'll be looking into the outcome at 5 years down the line, that is 2025 or 27. And we hope that if these results are positive, we can think of this utilizing these modalities for screening. However, as of now, if we look into the guidelines, CT coronary angiography is given a class 3 recommendation. Coronary calcium scoring has been given a class 2B recommendation. This is the ESC recommendation. In fact, all other modalities other than coronary artery calcium scoring and plaque detection by carotid ultrasound is given a class 3 recommendation by ESC. This is the recent 2021 ESC guidelines. 2019 ACC/AHA guidelines also says that in adults at intermediate risk, here only you should consider using coronary artery calcium to guide clinician-patient risk discussion. This is the US Preventive Service Task Force recommendation, and this is their recommendation of 2018. They recommend against using any modality for screening in asymptomatic adults to prevent CVD events. So coming to the question again, routine non-invasive screening for coronary artery disease among asymptomatic adults, are we there? My answer is not yet. The House might differ, but my reasons being gaps in evidence, logistical issue and accessibility, risk and cost of screening, and compliance of public at mass level. Yes, there are data which has shown positive results. There will be more data which will be coming up in future, and they will guide us whether we can utilize these methods for screening. But implementation of this method, logistic of this method in a country like ours will be a real challenge. Thank you for your patient hearing.